Your time starts now. Let us have the continuation of the same patient so that it makes more sense and your mind will be in groove to discuss it further. You have evaluated this patient's urinary symptoms. His IPSS score is 28 out of 35. His QOL is 5 out of 6. There is no indications for any blood test or urodynamics. His uroflowmetry showed maximum flow rate of 9 ml per second, showing a nice obstructive pattern. No other suspicious findings like box pattern or flat curve suggesting urethral stricture. So your outcome is a man quite healthy otherwise with very symptomatic voiding LUTS. How are you going to handle him further?
I'll first of all start off with conservative advice, conservative management advice in terms of modifying his fluid intake. But given the severity of his symptoms and that he has a prostate of more than 30 grams, he is at a high risk of progression as well. And I'll therefore counsel him and offer him combination medical treatment in the form of tamsulosin, so alpha blocker and 5-alpha reductase inhibitor, and I'll counsel him about the side effects. But during this discussion, also ascertain what his level of sexual activity is and his expectations are.
Okay. Regarding the behavior modifications, what specific things you will discuss with him?
I will advise him to reduce caffeinated drinks. If he's experiencing, for example, nocturia, then I'll advise him to limit his fluid intake in the evening. And there are no other specific measures that I'd mention.
Okay. Why intake of caffeine is not good for the patient's symptoms? In which way it interferes?
So caffeine is a drug which causes diuresis. Therefore, there'll be a high volume of urine in the bladder, and it's more likely to cause frequency, and it can also cause bladder urgency.
Okay. So, is there any role for phytotherapy in this group of patients?
Phytotherapy in the NICE 2015 guidelines is not recommended as first-line treatment. There has been some evidence demonstrating its effectiveness against placebo, but not against formal pharmacological therapy, and the evidence base is limited.
Okay, so what are you going to treat him with?
So I will start him on combination treatment with tamsulosin 400 micrograms once a day and finasteride 5 milligrams once a day.
Is there any role for giving anticholinergics to men with LUTS?
They are recommended if the patient has overactive bladder symptoms as well, or if storage LUTs have not improved if the patient's already been on tamsulosin. However, I would want to ensure that the patient does not have a high residual volume before starting them on anticholinergics.
Why are you starting him on tamsulosin? What is the reason?
This is from the NICE guidelines. This man has moderate to severe LUT, as evidenced by his IPSS, and his prostate size, as estimated by DRE, is more than 30 grams. And there is also evidence from various studies with regard to the combination of tamsulosin with 5-alpha reductase inhibitors in reducing the risk of progression of BPE.
What are the side effects of alpha blockers?
The main side effects are postural hypotension, retrograde ejaculation, rhinitis, and then tamsulosin can cause floppy iris syndrome if not discontinued prior to cataract surgery.
What is floppy iris syndrome?
Sorry, I can't recall.
Okay. So, what are the side effects of finasteride or 5-alpha reductase inhibitors?
The main side effects are ejaculatory and erectile dysfunction, a reduced libido, and gynecomastia.
Okay. What types of 5-alpha reductase enzymes available?
There are two types. There's type 1 and type 2. Type 1 is expressed by the liver and the skin, and type 2 is expressed exclusively by the prostatic stromal cells.
So what are all the types of medications available?
For 5-alpha reductase inhibitors, there's finasteride and dutasteride. Finasteride is targeted against the type 2 isoform of the enzyme, whereas dutasteride is targeted against both forms.
You said you want to start him on finasteride, and you said dutasteride blocks both type 1 and type 2 5-alpha reductase inhibitors. So why you are not choosing dutasteride?
Finasteride has a lower acquisition cost, but dutasteride, although it works against both forms of the enzyme, as mentioned before, type 1 is expressed in the liver and skin, and plus there is evidence specifically for finasteride from the PLES study.
Okay, what is PLES study?
So it stands for the PROSCAR Long-Term Efficacy and Safety Study. In this, there were more than 3,000 men randomized to receive either finasteride or placebo over a 4-year period, and it found that finasteride significantly reduced the likelihood of acute retention and bladder outflow surgery compared to placebo by 57 and 55% respectively.
Okay. What are all the studies which support combination of alpha blockers and 5-alpha reductase inhibitors?
So these were MTOPS, Combat, and also Conduct. In MTOPS, it found the arms were monotherapy with doxacin, finasteride, combination therapy, and placebo. And it found that combination therapy compared to all arms significantly reduced the likelihood of progression. In Combat, men were randomized to monotherapy with tamsulosin and dutasteride and combination therapy with no placebo arm. And again, this had similar findings in reducing the risk of acute retention and bladder outflow surgery.
What medications were tested in Combat?
So this was combination therapy alone of tamsulosin and dutasteride compared to watchful waiting.
Okay. Is there any role for any other medications other than what we discussed in male LUTS?
So if a patient has storage LUTs, then there is a role for anticholinergic medications and also beta-3 agonists, which is essentially mirabegron. There are no other. There is also a potential role for tadalafil if there is pre-existing erectile dysfunction, as it has been shown to have an improvement in terms of male LUTs as well.
Okay. If a patient has no erectile dysfunction, is there any role for tadalafil in treating only LUTS?
That effect has not been. That effect is not recommended routinely in any guidelines, so I would not use it as treatment solely for LUTs.
Okay, so you said you are going to start this patient on combination medication. How are you going to review him further?
Given that this patient is being started on tamsulosin, I will arrange to review them in 4 to 6 weeks. And this will be with a repeat urinalysis, IPSS, uroflowmetry and residual bladder volume. If the patient's symptoms are improved, then I will arrange for a further review in 3 to 6 months as per the NICE guidelines.
Why are you doing urodynamics? How are you going to do that? I mean,
uroflowmetry.
No. You mentioned about urine test.
Yeah.
Why do you want to do urine test? Which method you will do the urine test?
So for the uroflowmetry, are you referring to the uroflows?
Just the urine test.
The urine dipstick.
Why?
So this is to exclude any evidence of infection, and also, for example, if there is if there was any hematuria initially, then it's to ensure it's not persistent.
Okay, good. And what are the complications of benign prostatic enlargement if left untreated?
So it can cause acute urinary retention, bladder stones, bladder outflow obstruction, leading to UTIs.
Okay. How you did it? The 10 minutes completed now.
Okay.
Any feedbacks from you?
I don't think so. I think obviously floppy iris syndrome is something to just quickly revise on. And I think in terms of treatment choices, I think I justified them. But I'll wait for your feedback.
Good. As usual, again, nice presentation, very nice level, nice roping in of the evidences as needed. As usual, I will be very critical and try to give you a little more push towards the positive end of the mark spectrum. So, floppy iris syndrome, the correct terminology you need to use is intraoperative floppy eye syndrome, IFIS syndrome. So what happens is whenever a patient is on alpha blockers, especially tamsulosin, when the patient goes for cataract surgery, when they scoop out the cataract affected part of the lens is supported by the iris, and then iris will become very floppy because of presence of alpha blockers in the iris, which is blocked by the alpha blockers. And since the iris is so floppy, you can't keep a intraocular lens. If you keep intraocular lens, the lens will fall out, and no way patient can have the completion of the cataract surgery with intraocular lens. So patients are advised to stop tamsulosin at least for 5 days, if not 7 days, if the patient's symptoms are manageable, so that there will be like a washout of alpha blockers from the patient's bloodstream. So the 5 alpha blocking of the iris due to the medication is reversed. Iris will regain its strength. So intraoperatively, the intraocular lens can be adequately placed, and then after 24 to 48 hours, patient can retake the medicine. And then even if the iris becomes floppy, because of the presence of the intraocular lens, it will be still nicely functioning. So the only problem is intraoperative lens placement. So patient, because this group of patients, there is a good possibility they will end up in cataract surgery. So patient should be aware of stopping, and of course the onus lies on the specific ophthalmologic consultants to make sure the history is properly gathered and the medications are properly stopped. It is just like we stopping the anticoagulants before any biopsy or any surgery. It will happen automatically with them. And few other things just to complete. Salpalmito, as you said, you can comfortably say there is no role for salpalmito at this present age. It is also nicely supported by the Cochrane review and also randomized controlled trials. And very rarely, if there is any study with salpalmito being useful, there is no real quantification of the quality of the tablet, and they have mixed the tablets with some finasteride, tamsulosin, etc. So the effects may be due to them rather than the actual plant product. And when you're explaining the finasteride based symptoms or side effects, you can bring in breast tenderness and breast swelling and lack of libido and rash. Lack of libido is the most important finding of finasteride, because tamsulosin or any alpha blocker, it will not affect libido. It will cause only anejaculation. Try to bring in the terms anejaculation rather than retrograde ejaculation, because as per the latest findings, tamsulosin relaxes the ejaculatory duct so that the ejaculation won't happen. The same way it relaxes the bladder neck, VUJ for medical expulsive therapy, etc. And
for finasteride, is it also, because I know there's evidence about it being associated with higher grade prostate cancers, but should I just leave that alone and not?
Yeah, it is like if you open that, nothing wrong in it. You can say that because of the lack of time, you can, in the actual 10 minutes, you can say that there is an evidence to show that the finasteride patients are having high chance of finding high grade prostate cancer. I will warn my patient, just stop there. Because there is no real strong evidence to say that finasteride causes high grade prostate cancer. because when we dissect those studies, the outcome is finasteride results in shrinkage of prostate, especially the transition zone, which is always not the site of prostate cancer. Because of the shrinkage of the prostate, when you do the biopsies, you will end up finding more chances of prostate cancer and also more chances of high grade cancer. There is
Yeah.
no evidence to say that finasteride causes high grade cancer, but
Yeah.
people who are on finasteride have high chances of finding high grade cancer, which
Yeah.
possibly may happen in spite of the finasteride also. Finasteride only enables us to find them. It is like you're searching for a key in a drawer full of lot of items, your chances of finding the key is less. But if the whole drawer has only a key and maybe a couple of papers, the chance of finding is more. It's as simple as that.
Yeah.
So that's why when you are saying, you need to term it like finasteride will result in high chances of finding high grade prostate cancer. There is a
Yeah.
possibility the examiner may stop and ask, can you explain it further? So you should be able to say that there is no evidence to say finasteride causes high grade cancer. It only causes shrinkage of the transition zone, resulting in relatively high chances of finding the high grade cancer.
Yeah.
And in the combat trial, the medications tested were tamsulosin and dutasteride. There is no placebo or watchful waiting arm. The reason is already the MTOP trial is completed. MTOP trial clearly proved that the placebo arm is not useful. So ethically, when they do the combat trial, there is no point in having a placebo arm and making the men suffer. So they tested only the tamsulosin dutasteride combination and non-combination single drugs. So there are only those arms. There is no placebo arm. And as you said, PDI5 inhibitors, there is no role for solitary LUTS symptoms if there is no coexisting erectile functions.
Yeah.
And it is clearly mentioned in the NICE guidelines. But if you go through the studies individually, there are a lot of studies to prove that tadalafil 5 milligram is good in LUTS in men without erectile dysfunction. But because of the cost concerns, at least for UK, NICE guidelines is not advising a patient to take monotherapy tadalafil 5 milligram once daily, because the outcome with the amount of money spent is not useful compared to giving just a tamsulosin, which is much cheaper.
Yeah.
Okay.
Yeah.
Good. Any other questions you have before we go to the next scenario?